Okay, good evening, everybody. Welcome to our Q&A with Dr. Moloi from Joburg Fertility Clinic. So tonight's fertility talk, we are doing a bit different. We haven't chosen a topic. And we've just realized that every week, it's as if we're not getting through all the questions. So everyone's got a question for the doctors and the questions come through us afterwards. And we thought, let's give you an opportunity to ask all your questions. So this week, what I did was I did some stories on our social media pages, and I asked everyone to just contact me and DM me if they have any questions. So we've chosen 10 questions tonight, but if you have any questions, please just pop it in the comment section. I'll be checking through while we're doing our talk and while we asking all the questions. I'll be checking on the questions that you guys have left in the comment, and we'll try and get through all of those with Dr. Moloi. So again, thank you, Dr. Moloi, for joining us. Dr. Moloi has done quite a few talks with us now, so everyone knows him. Thank you for taking your time out again to do this talk with us, Dr. Moloi.
Yeah, thank you to join the team.
Okay, great. So we're just going to get into the first question. We've got the first question was from Gabriela. I hope Gabriela is online and she's listening. So today's question from Gabriela was, my doctor did an HSG test and the results showed my tubes are blocked. However, she did say it could be that my body was tense and caused the dye not to go through. I'd like to know if it's best if I get a second opinion on the HSG, or if I should do the laparoscopy, then try to conceive naturally, or should I go straight considering IVF, as she advised me, because doing a laparoscopy does not guarantee I will conceive naturally. So it's quite a long one, Dr. Moloi.
It's quite a long one and a very interesting question. Actually, the issue of using HSG, which is hysterosalpingogram, in checking the patency of the tube, you have to do some few, things, or look at some few things really with an interpretation. That interpretation differ from doctor to doctor. I would say the first thing I would be more interested to Gabrielle is the age of Gabrielle, which is more important. Then the second thing I would also look whether from Gabrielle there's any history of infection of some sort, which may have led to probably blockage of the tube, or there's even any history of endometriosis. That background is very important to interpret the HSG. We say both tubes are blocked. Then if both tubes are blocked, yes, it can be what you call a false and a negative or positive result. In that case, laparoscopy can help, where we do laparoscopy and dye. And those, it will be with young patient, actually, to be sure. But if, it's above 35, I would say with an HSG already showing that both tubes are blocked, IVF it's an appropriate actually move. But if the patient is still very young, below 30, you can go laparoscopy and check probably that is true, that everything is okay. With laparoscopy, you'll see the outside of the tube. Is there any infection? Is there any, hydrosalping? Is there any, endometriosis, which may lead to tubal blockage? In that case, I would say yes, a second opinion may be important. But with the same doctor as well, you can either do, if you are young, below 30, laparoscopy and check, then go on with your IVF. Really, they are blocked.
Okay, that's a very, very good answer, Gabriela. I hope you've been listening to that. And then the next question was from Tawanda. Tawanda wants to know how much is your consultation fee, and after how long of trying to conceive should one visit the fertility clinic?
Yes. Yeah, I know this question of consultation fee. Let me start. Usually the consultation fee by itself, which is really history taking, it should amount for something in a fertility center between 500 and 1,000 rand. But what we do usually in fertility center like Joburg Fertility, we'll actually do all the basic investigation, like you go through an ultrasound and check that everything is okay. You go through your bloods and check that everything is okay on that side. Therefore, about 5,000 to 3,000 you're paying. You're also paying with some investigation. And at the same time, in that consultation, the couple will look at as well as the sperm count of your husband. Therefore, consultation is not confined to you per se. is confined to both you as a couple and
Yes.
to find out what may be the problem. Then the other thing is that she's been trying to conceive. Also, I understand that. Then the most important thing actually in IVF and the way, Joburg Fertility will approach this kind of problem, the age plays a major role. Therefore, if you've been trying to conceive, and you are above 35, definitely something must be done, and very quickly. Then if you're still young, below 35, then we can say fine. If you have tried for a year or even 2 years, that gives you at least 87% chance of being pregnant. If that you couldn't achieve, then that's the time to move on to get to the fertility specialist as soon as possible. The problem we have as well in South Africa, looking at other countries as well, our patients tend to present 10 years later. Hence, then the fertility is much more expensive treatment at that age, above 35. And then the results are also low compared when, diagnosed early and you go to see your fertility specialist as early as possible.
Yeah. Okay. So thank you for that. Then the next question is from Tawanda. Can women get pregnant naturally after the age of 42, and what helps the process?
Yes. At the age of 42, yes, we can be pregnant spontaneously or naturally, but it depends on basically one thing or two things. If your husband's semen or sperm count or semen analysis is normal, and you at the 42, you still have a number of eggs. In other words, when you do MH, you find out you still have a number of eggs, or you have an MH. Usually I'd say at that time, I'll expect the MH to be between 5 and 8. Then it's acceptable at 42. Secondly, we have to make sure that you don't have any fibroids, we don't have any tubal blockage, and everything is normal. Then at 42, you can spontaneously get pregnant. Now, but if you say, fine, I'm 42, I've been trying to be pregnant naturally for 5 years, automatically it will be difficult for you to be pregnant naturally. Therefore, you have to, get help. Yes.
Okay, great. And I'd yes, definitely, Nomfundo, it's Tawanda. Tawanda, I would say, go and see a fertility specialist if you haven't yet. Go and make that appointment, because at 42, I think it's the best choice you can definitely give yourself is to go to see a fertility specialist. And then we've got Nomfundo. Hi, I would like to know, what does it mean when your doctor tells you she doesn't see your ovaries? So I don't know if this is a difficult one for you, or if she's not clear, maybe she didn't hear doctor properly or something.
No, I understand.
Okay.
Most likely, Nomfundo went to see a gynae or a fertility specialist, and they probably did an ultrasound. And probably then there are 2 times of ultrasound. If you have done, Nomfundo had done an abdominal ultrasound, sometimes it may be difficult for the doctor to actually see the ovary. To see the ovary, most of the time there must be at least follicles in there so that you can see them. Then the most appropriate gynecological ultrasound, which is endovaginal, is much more close to where the ovaries are, and the doctor can scan left and right and probably see. Now, most of the gynaes we expect in gynecological ultrasound, they should be able to see the ovaries, and then they should be able to see even the ovaries of a person who's already postmenopausal with atrophic ovaries. Therefore, probably I would say it may be a technical problem. The doctor may have done an abdominal sonar, which can be very difficult, it can miss the ovaries. Therefore, you probably request the doctor to do a gynecological or endovaginal ultrasound. Definitely you'll be able to pick the ovaries.
Okay, great. The next question was from Owen Tando. She wants to know what makes fibroids grow so quickly. So last year, September, I had fibroids removed, but yesterday I was told again that I have 7.5 and 5.4 centimeter fibroids. What causes them to grow so quickly? And what can I do to delay the growth? She's 34 and she doesn't have any kids.
Yes. No, Lutando, it's the question actually is right to ask why the fibroids are growing so fast.
Yeah.
But I wouldn't say it's your problem. Your problem really, Tando, is that, yeah, Tando. Your problem is really to get pregnant. I would say at the age of 34, already you're approaching 35, then you're approaching whereby you have actually the fibroid and probably low quality of eggs, even low number. I would suggest that you probably go to the fertility specialist, look at those fibroids and look at look at the fibroids, the size, where are they situated, their location and so forth. If the fibroids are really out of endometrium and so forth, and even assess the tubes, most likely with the 7.4 fibroids, because 7.4 probably is the size of already of the uterus. Therefore, they are big. There may be mechanical pressure which is making you not to be pregnant. Then in that case, you'll probably need to remove them. There are two options. You can remove the fibroid first and go for stimulation to get pregnant, IVF. Or you can do stimulation, get the eggs, then remove the fibroid after. Both of them, it's up to you how to look. But I'd say you really need a fertility specialist so that he can go through to help you with the fibroids and as well to assist you to get pregnant.
Okay, wow. Okay, that's a good one. Owatando, if you're in the Joburg area, you can contact Dr. Moloi. I will actually leave his details for you. At the end of the talk, I will send all of you his details as well. If you are not seeing any of you that is asked questions, if you haven't seen a fertility specialist yet, or you're looking for one and you're in the Joburg area, I will give you doctor's details and you can contact him. I've got a few questions coming through on Facebook as well. We'll get through to them now. We're just going to try and finish these ones first, guys. So, okay, so we've got Marion. Marion is saying, is it possible that if you're over 2 years not seeing your period, she's not seeing a period for 2 years, but there's still a change in getting, is there still a chance, to get pregnant, to conceive?
Yes. Marion, it's very important that you should have what is called a regular cycle. Immediately not seeing your menstruation at all, it means you're not ovulating. Therefore, the chances that you can get pregnant are almost to zero. Therefore, there are a lot of things which can cause you to have probably what we may call a secondary amenorrhea, whereby you're not seeing. It can be polycystic ovary. It can be, if you have endometriosis, actually, the damage to the ovary. It can be even Asherman syndrome, whereby actually the ovaries are ovulating, but the endometrium is not actually built up to have a menstruation. Therefore, you really need to get a fertility specialist to go through with you, identify what's the problem. As I said, I've mentioned almost 3 or 4 causes in this situation. But I would say get a fertility specialist to try to check exactly what's the problem and then help you to get to pregnancy if you want to. I think so.
Okay, great. Okay, then we got Rakuba. She says, a year trying to conceive after ectopic pregnancy in 2011 and remove tube. What is my best course of action to conceive?
Yeah. Yes. Yeah. Rakuba, the most important thing is that we have one side or history which we know that in 2011 you attempted to be pregnant and you had an ectopic. Now the causes of ectopic come into play in this situation. The ectopic do affect the tubes. You may have adhesions in the tube. You may have endometriosis. You may have congenital abnormalities of the tubes as well. Therefore, during that procedure, the doctor most of the time, if he's a fertility specialist, will definitely remove the ectopic pregnancy, but make sure that he check the other tube whether it's normal or not. But if it's an infection, the chances are both tubes are affected. And with the periods you guys have been trying as well, tells that both tubes may have been damaged. Then advice it will be to get straight to the fertility specialist, maybe go straight for IVF so that you can achieve pregnancy as soon as possible.
Okay, great. Then we've got Zulfa. Zulfa saying diagnosed with PCOS and insulin resistance more than 10 years ago. She lost weight but not able to maintain a regular cycle. How can I regulate my menstrual cycle and aid in potential healthy conception?
Yes. Zulfa has been diagnosed with polycystic ovary at 7. It means that there's also a weight problem associated with it, which we do understand, because PCO actually is a metabolic problem. But it's very important that you know, looking at the year probably of 10 years, I don't know how old is Zulfa, but if Zulfa is already above 30, I would say probably need to go straight to the fertility specialist, or for the whole, even if it's younger. Because the most important thing is to really assess all the female reproductive system and even check the partner as well. But the most important thing, there are 2 ways you can approach the problem of polycystic ovary with insulin resistance. The one is, which is embarked on to get a weight loss, which may be difficult. The second one is to start what is called ovulation, induced ovulation, which is ovarian induction, whereby the doctor, if the tubes are pattern, everything's okay, can just put you on induction and follow you. Now, in Joburg Fertility, actually, we've got a nice protocol of this patient of PCOS, because we're seeing a number of them. Most of them, I prefer to put them on metformin, and then follow up with Femera, and then see whether they do ovulate. And most of the time, the cycle become regular, and then those patients within 3 to 4 months they get pregnant. But if there's another underlying, which is from my experience as an endoscopic surgeon as well, I see a lot of patients with PCO as well tend to have endometriosis. Therefore, those things should be cleared up first, so that you can embark on your issue to get pregnant.
Okay, great. Then we've got another one. Well, I think let me ask the last one quickly, because I think it falls under the PCOS thing. Says, I have a question for Dr. Moloi. Is ovarian drilling doable for patients with PCOS?
Yeah. Yes. Ovarian drilling, you can use for patients who have PCOS, but it's used usually after you have started on the medication, like I said before, metformin, Femara to induce, and nothing happened. And then you can take the patient in and do laparoscopy and do the drilling. Now, the ovarian drillings got also protocol. Is very important. Some of drillings can be dangerous, because most of the time people use diathermy or cautery, which may damage the ovarian reserve. Now you are left with less ovaries. But you drilling 2 or 3 per ovary, that should actually change your FSH, LH, and then hormonal profile. Then you can start ovulating on yourself. But what I see in this patient, who probably I've done some laser either, or do some drilling with harmonic, which is actually doesn't kill a lot of cells of the ovary. Then immediately after that, I put them on medication at set, so that I can follow them. They can get to ovulate, and they can get pregnant quicker as well.
Yeah, so the reason why I actually jumped to that question was years ago, I don't know, I've said to you already, there's a lot of doctors. So some doctors would say, no, they don't like to do ovarian drilling. Some doctors are say, yes, they will do ovarian drilling. I've actually had ovarian drilling done. I had it done twice. And the ones when I had it done, the first time I had it done, I actually ovulated, because I suffer from PCOS. I ovulated and I did conceive. Unfortunately, it ended in a miscarriage. But I actually ovulated naturally, and I conceived for the first time. So I don't know, it's just my opinion. It's not a professional opinion or anything like that. But ovarian drilling, yeah, it's actually worked for me. But I think it's different for a lot of patients, doctor?
Yes, it's different.
It is for different patients. Okay, we've got another question is, Abimandla, what is the best way to deal with male infertility morphology issues? Can I still conceive by IUI? So it's a lady asking this for her husband.
Okay. Yeah, I think they've done a semen analysis and probably look at morphology. Now,
Yes.
then in that morphology, we look at forward progression. I think probably morphology, they look at the structure of the sperm, Then what they picked up, they probably were, the husband was falling below 4%, which is the low minimum. But I would advise really if they tried with whereby the structure, which is morphology of the sperm, is less than 4, most likely they can try IUI really and see how it happened. If IUI is not giving them the best, because with IUI, you can try to pick up only the most normal sperm and concentrate them and try to see that they can be pregnant. But that should be only 2 or 3 attempts. If nothing happened, then the best it will be go straight for IVF to get pregnancy.
Okay, great. Then I've got the questions that came through on our last few questions, Doc, came through on Facebook. It says, if you've got endometriosis, what is the procedure to fall pregnant?
Yes. If you've got endometriosis, what is the best procedure to fall pregnant?
Yeah.
Yes, if you have endometriosis, the most important thing on the diagnosis is actually to stage endometriosis. If you got minimal endometriosis, you still have a chance to be pregnant naturally. If you've got moderate to severe endometriosis, most of the time can affect the tube, and then you can have difficulty. But remember, endometriosis doesn't only affect the tubes, it also affect the ovulation of the ovary, especially the one which I talked about, which is either moderate or severe. By that, you're looking at endometrioma, you're looking at endometriosis of even around the fallopian tube, the rectal, the bowel, endometriosis and bladder. Those one usually do affect even ovulation itself. And those patients after treatment with surgery, it's better to go straight for IVF. But if it's minimal, the tubes are right, you can do laser, and there is no resection you need of the endometriosis, then the patient probably can be pregnant naturally or with the IUI.
Okay. And then I think the same lady asked, do we have a doctor in Namibia? Hendrina, you can actually come down to Joburg. I'm sure it's easy to get to Joburg from Namibia and see Dr. Moloi. I'm sure you can contact him and you can arrange to actually have treatments done with Dr. Moloi here in Joburg Fertility Clinic. We've got the next question is, Doctor, can one fall pregnant if both fallopian tubes are blocked? Is there treatment for it or?
Yes. If a person can get pregnant if both fallopian tubes are blocked, but with assisted reproductive technique. By that, I mean IVF or ICSI. But, the other method, natural method, the chances are extremely low. Therefore, I would advise if you confirm blocked tube, look really to do IVF so that you can get to pregnancy. The delay which we have in most of the patients which present late is that they go and try all the other medication which they believe they can unblock the tube. Yeah. One of the methods is just putting whether a doctor put fluid and just see is blowing the tube. There's really nothing like that. It's actually, causing a lot of problems. That kind of procedure where you say blowing the tubes and so forth cause a lot of what is called hydrosalpinx. You pushing that fluid into the tube, which is infected, and it stays there, and the tube start bulging and become big. Then hydrosalpinx is got also a problem when you go and do an IVF. Then the pregnancy become low because that fluid it tend to go into the uterus. Therefore, I would really suggest that immediately your tubes are really blocked, be referred to a fertility specialist center so that you can get IVF as early as possible. Now, the reason why you should go earlier there is very simple. The younger you are, you've got more eggs, you've got good quality eggs, and IVF success is very high.
Yeah. Well, that's actually very, very good advice. And I've never heard that advice given before. So thank you for that, doctor. So you've heard if you've got both tubes blocked, rather go and see a fertility specialist before you go through any sort of courses or any medication or anything like that. Rather see a fertility specialist so they can give you the best, you know, best way to actually get to where you want to be as in conceiving baby. I've got Andrina's asking, same one. Does she have to come with her husband? Yes, Andrina, you have to come with your husband for treatment. I will give you doctor's details at the end of the talk. So if anyone has any other questions, you are welcome to email Dr. Moloi. You can email directly to me, or you can email Dr. Moloi, or you can give them a call as well. Doctor, if you just leave your details for all the ladies, please.
Yes, we are in Joburg Fertility Center, based in Fourways in Sandton. And we do all the procedures. We do endoscopic procedures, we do IVF, ICSI, and so forth. Therefore, the chances that we go, do surgical procedure, prepare you for IVF, rather than, we get prepared by another doctor, then come to us. But we do everything in that center. Yes.
Okay. Okay, great. I will send doctors you can find him on he's on Instagram, he's on Facebook, as well as the website Joburg Fertility. Is it joburgfertility.co.za? Am I right?
Yes,
fertility.co.za. Okay, thank you very much, doctor. Thank you for taking the time out to do this talk with us again. And I hope you've answered. Thank you for answering all these questions. And I hope that some of these women will make the right decisions to actually go and see a fertility specialist, especially so that, when it's not too late. Now, while they can.
The earlier they come, the better the result. Yes.
Absolutely.
Thank you, Leanne, for the opportunity as well.
It's a pleasure always, doctor. Have a great evening. Thank you.
Thank you.
Bye.
Bye-bye.